Yeah, so there's a lot happening in the field of pediatric dermatology, and it's in a lot of different disease states. So certainly atopic dermatitis has, these new topical nonsteroidals that are being handed to us, extended experience with dupilumab as a biologic agent impacting on development of comorbidities and allergies. We have new biologics that have been approved, nemolizumab and lebrikizumab in the adolescents, so sort of getting, wrestling with that in the atopic derm world. Vascular lesions, there's been this incredible change in understanding of how some of our hemangioma-like lesions actually have specific mutations, so they're sort of malformation-like, and how some of our malformations are very particular with certain genomic aspects of the vascular malformations presenting in a different way with different sets of risks and potentially targeted therapies. Vitiligo is a hot field. We have new guidelines for topical treatment of vitiligo, and we know there's some systemic agents that are being studied in adults that may impact on children as well with vitiligo. Acne, where there's a lot more data on acne fulminans and a lot more options, and then a reconsideration of the place of hormonal therapy with acne as well. Hidradenitis suppurativa, a disease that we still need more. We haven't had a new drug approved in adolescents or children with HS, yet we see a lot of that disease. So I think those are some of the big highlights in pediatric derm. Multiple disease states with new drugs or new drugs coming, but still a lot of clinical need for our children and adolescents. Yeah, so the U.S. healthcare model is a difficult one, and every day in clinical practice we're trying to figure out what we think's right for the patient, with the patient making their shared decision making, but someone else is influencing what we can get, and that happens to be who their insurer is and what their policy is. So it's a juggle, and as we also try to figure out as practitioners, how much time and energy do we have for people in the back to go through prior authorizations? So, we try to use our systems-based approach and our experience to figure out what we can get covered and what's right for that individual. It's an external system issue that we have to deal with, but part of real life. On the other hand, the newer drugs that we're getting have totally changed our ability to manage the disease. And so our positive messaging to patients is we can really get them to minimize the impact of eczema on their involved patient or family member. And it's just a question of us figuring out what's the medicine that's best for them and then working hard to get it for them.